we wanted to apologize for the technical difficulties. We decided to record the webinar and make it available for everyone. Thank you again. Today we have a special presentation by Dr. Michaela Grita, Managing the Balance, Insights into Ozempic, Mounjaro, and Nutrient Deficiencies. We have incorporated the slides to be sent out at the same time as the recording will be sent out. If you have any questions, feel free at the end to email Dr. Grita. This webinar will be recorded and sent and will be available on SpectraCell's YouTube channel. At this time, it is my pleasure to present Dr. Michaela Grita.
Thank you, and good evening, everyone. I am so happy to be here to talk about Ozempic and Mounjaro as two drugs that seem to make the news almost every day. And I'm also very passionate about drug-induced nutrient deficiencies. So I was thinking when I was preparing for this webinar, how cool it is to get something that so many people are concerned about and do the research. And tonight I'm going to show you what I came up with. But before I go there, I want to show you or tell you a little bit about me. I am a clinical pharmacist and a research pharmacist. I have been doing pharmacy basically for the last 20 plus years. And when I was working in the hospital, every admission order sounded something like this. If the patient has a fever, give them this. If they have a headache, give them that. If they have constipation, this. If they have diarrhea, give them that. And it felt like I was handing them a big giant capsule that had basically all the medications that they could possibly need during their stay. And then in addition to that, I would always wonder like why people would end up taking 3-4 medications for hypertension and 2 to 3 medications for diabetes, in addition to potentially 2 types of insulin. And those were the thoughts that were going through my head every time I entered orders for these patients. And tonight, I'm going to share with you the answer that I came up with as I was preparing, and the answer as I found in the last few years as I was going deeper into functional medicine. So Ozempic and Mounjaro in the news. Basically, media calls these drugs wonder drugs. They show that surprisingly, these medications lead to weight loss that basically, I don't think the makers really anticipated that this would happen. And now that it did, for example, semaglutide, the makers of semaglutide or Ozempic, they actually submitted to the FDA more studies, and they came up and they brought on the market Wegovy, which is exactly the same drug as Ozempic, just a higher dose. Mounjaro is sorry, I'm having trouble pronouncing that word, but Mounjaro does not have another counterpart that is on the market just for dealing with weight loss the way Ozempic does. But by the end of this year, Eli Lilly is expecting that they will. These are more things I found on the news, like journal articles and things like that. Semaglutide, they're hoping that will be something that can be used to fight addictions. They are saying that there's a small phase 2 study of 60 patients underway in Toronto that will also look at depression. This is that particular study. It started in 2020. It's still enrolling patients, and they are trying to figure out what the results will be. There's another study that is still enrolling as well, and they're hoping that semaglutide will bring some relief in early Alzheimer's disease. They're also looking at semaglutide to be used along with another investigational drug in non-alcoholic fatty liver. This is the news about that study that I actually found online. I think it was on social media or somewhere. And interestingly, they are hoping that this type of medications will restore natural killer cell metabolism, which is thought to be the cause of obese people being more prone to getting cancer. So truly, if that's the case and this medication will end up being useful in all these diseases, these are wonder drugs. This is another clip from some other media, and they are thinking that Mounjaro is going the next game-changing medication. And as I mentioned a second ago, they are awaiting FDA approval to treat weight loss. But before we go into what could be the concerns with these drugs, let's talk a little bit about adverse drug events and why do we even care? We all know that all medications cause adverse drug events. In fact, in the US, adverse drug events represent the third leading cause of death after cardiac disease and cancer. It's also estimated that about 1.3 million emergency department visits per year are caused by adverse drug events, and about 350,000 of those people per year will be hospitalized for further treatment after presenting at the emergency room. More than that, about 10 years ago, they were saying that about 50% of the drugs approved in the US commonly deplete nutrients, and they were thinking that about 30% of the side effects from medications are related to drug-induced nutrient deficiencies. So this is very important, and to some extent, I think this is the answer to all my questions that I had as I was working as a clinical pharmacist. When we give medications, those medications will cause nutrient deficiencies, and those nutrient deficiencies will cause more disease or worsening of current diseases. Here are just few mechanisms by which nutrient depletions do happen. Drugs will purely and simply bind the minerals and the vitamins, causing them to be excreted. They can also alter the pH in the stomach, thus leading to poor digestion and poor nutrient absorption. They can also inhibit enzymes involved in the transport of nutrients around the body, and also they might inhibit enzymes in activating nutrients or transforming them in a more usable substances. So for example, most hospitals and most pharmacies like CVS, Walgreens, Costco, they will sell a vitamin B12 in the form of cyanocobalamin. Well, once the medication is absorbed inside our body, it needs to, the cyano group needs to be cleaved off, and then it needs more chemistry, biochemistry needs to happen, where a methyl group will be attached to the cobalamin to make methylcobalamin, which is the active form. So drugs can inhibit all those enzymes that are required in all these steps. And also drugs can destroy the taste. So sometimes you hear of medications that would lead to metallic taste. Those people usually have a hard time eating because none of the food would taste good. And other drugs will cause nausea, and those people also will have a hard time eating due to nausea. And other drugs will decrease appetite. And when the appetite is decreased, again, the food intake will go down. So let's talk about the drugs. What do? For example, Ozempic is a GLP-1 agonist. GLP-1 stands for glucagon-like peptide 1, and it's an incretin hormone, which basically stimulates insulin secretion in response to meals. So this hormone is made in the small intestine and in the colon, and it stimulates insulin secretion only when there is glucose in the bloodstream. It also delays stomach emptying, which basically will slow the carbohydrate uptake, thus leading to a more gradual increase in the blood glucose levels, as opposed to spiking high levels immediately after eating. This hormone will also curb the appetite. And in animal study, we've seen that this hormone will promote regeneration of pancreatic beta cells and fight programmed cell death, thus improving survival of existing beta cells. The other one, the GIP agonist, stands for glucose-dependent insulinotropic polypeptide. And Mounjaro is actually both, is a dual hormone. It's a GLP-1 agonist and it's a GIP agonist, where Ozempic is just a GLP-1 agonist. GIP is also an incretin hormone, and in many ways it works very similarly to GLP-1, but it is made in the upper small intestine, and it also will help with release of glucose only when the cells in the small intestine come in contact with glucose. Also, it will affect the pancreatic beta cells, and it will promote beta cell proliferation and survival. This hormone will also stimulate insulin secretion. And because pictures are worth 1,000 words, I have this picture here that will show you what I just kind of said. But basically, this drug, semaglutide, will increase insulin secretion. It will increase insulin sensitivity in the liver. It will decrease fat deposition, gastric emptying, calorie intake, and fat absorption. It will also increase satiety in the brain and insulin sensitivity, neuroprotection, and cognition. Okay. This is another picture I found, which talks about the mechanism of action of tirzepatide, Mounjaro. And in many ways, it's similar to Ozempic, but in addition to that, it will decrease the gastric emptying. It will also have benefits in the cardiovascular area. It will decrease the blood pressure, the lipids, and in the kidneys, it will improve the GFR, so it will improve the renal function. Altogether, this medication will decrease the weight, it will increase insulin sensitivity, decrease glucose, fasting glucose, and hemoglobin A1C. And this is another picture that shows a comparison between the two hormones and how their benefits in various organs. So let's talk a little bit about side effects. Basically, with this slide, all I want to show you is that these two drugs share kind of the same side effects. And for the most part, most people will experience this GI problems. In terms of how much or what are the chances, it's kind of hard to tell. And that's what I was saying with this percentages is like, if you look here, what's in parentheses is the placebo. So while we say, okay, Ozempic will cause 16 to 20% chance of nausea, well, in the exact same trials, they saw 6% in the placebo. So in other words, my question is, well, how did they choose the well, the people that got the placebo were also sick, so maybe just the illness that these people had was good enough to cause that nausea, right? So it's not, I don't want to really dwell that much on the percentages. It's just to show that the GI side effects are there and they are the most common. There's also severe side effects, and there's a risk of thyroid C-cell tumors, and actually FDA put a black box warning on these drugs for that. And I want to point out that actually none of these drugs show that in clinical trials, but because an older I think GLP-1 drug had this occurring, FDA was just proactive and just put a black box warning on these two drugs as well. And acute pancreatitis, same thing. They actually they actually put a black box warning. FDA put a black box warning for both these drugs. There's other severe side effects like diabetic retinopathy, but it's temporary, and it shows that people that had a history of it when they started on the medication obviously had worse outcomes than people that did not have this complication. Both drugs can cause hypoglycemia, especially if they're on other diabetes medications or insulin. And they observed some acute kidney injury. Most of the times it was associated with people that were dehydrated because of nausea and vomiting and diarrhea. So more things that I thought it would be good to look at is what happens when people reach their weight goals and they want to get off the medication. What happens then? And the answer was found in the step 1 extension study. There was a step 1 study which lasted 68 weeks. It was a randomized double-blind placebo-controlled trial. It had 129 sites in 16 countries, and about 1,300 people were on semaglutide 2.4 milligrams. That's a dose actually for Wegovy. And they also implemented lifestyle interventions such as diet counseling once a month and workout about 150 minutes per week. And then they had a placebo group which only received the lifestyle interventions, and that was a 68-week trial. Then that was followed by step 1 extension, and some of the people from this study were added into this new extension. And what they did, they stopped the medication and they also stopped the lifestyle interventions. And they wanted to look at the body weight and the cardiometabolic risk factors, see if those changed back to the way they were prior to being on the medication. And the answer is that indeed at week 68, when the medication was removed, weight came right back. It didn't come all the way back to where it was, but close. The mean changes from week 0 to 120 were numerically greater in women versus men. It was if they had higher versus lower baseline BMI, and whether in the beginning they had normal blood glucose versus pre-diabetes. They also looked at subgroups with greater weight loss from week 0 to week 68. They had numerically greater weight gain from 68 to 120, but maintained numerically greater net weight losses from week 0 to week 120. And also they did look at cardiometabolic signs. So they looked at the blood pressure, both systolic and the diastolic. And after stopping the medication, they all kind of came back, including the C-reactive protein, indicating that inflammation was coming back, and hemoglobin A1C, the blood glucose levels were also coming back up. So I looked for literature on drug-induced nutrient deficiencies in relation to both Ozempic and Mounjaro, and I didn't find any documentation. And I have to say that I wasn't surprised, partly because unless a study is designed to capture this drug-induced nutrient deficiency, they are just not gonna see it. And so just because it wasn't designed in the clinical trials, it doesn't mean it's not there. So we don't know based on what literature is out there. Another thing is most trials are too short and they're not able to capture all the side effects or nutrient deficiencies. Again, if they're not built into the study, they're not gonna find them. Also, most of the clinical trials are too small compared to the actual population. So once the drugs come to the market, just United States has millions, like 350 million people. Now, not that everybody will be on this medication, but still compared to 200 patients versus like 1,000 to 3,000 people in a phase 3 clinical trial, you know, that's a big difference. And also the post-marketing period has been relatively short. Ozempic was brought on the market in 2017, Wegovy in 2021, and Mounjaro has been on the market only since 2022. And so only time will tell if these medications will induce any nutrient deficiencies. But until then, one way to deal with that is to extrapolate from the side effect profile. And we know that anybody that has vomiting and diarrhea, they will lose electrolytes. If they are nauseous, they're just not going to eat. So the food intake will go down. And so consequently, the nutrients will go down. Also, if the gastric emptying is decreased, those people will have very poor appetite. So the food intake again will go down and the nutrients will go down. And then the stomach acid was actually made more alkaline by Mounjaro. And so that causes poor digestion, which leads to poor absorption and will cause a decrease in nutrients and protein. And this, in addition to that, I have actually heard of people that are on the medication who, because their appetite is so poor, and they feel full for so much longer, they just can't eat more than 3-4 bites. And so then what they prefer to do, instead of eating food that's really rich in nutrients, when they do eat, they go for the ice cream and the crackers and the cookies instead of something nutritious. Another question that came from here was, well, what happens then if the protein absorption goes down? Then will these people decrease muscle mass? And there is a meta-analysis that looked at 18 randomized controlled trials that included a total of about 1,300 subjects. And they evaluate the fat-free mass, that's basically the muscle mass, and semaglutide seemed to show a significant decrease in the fat-free mass compared to placebo. But we do need to keep in mind that these drugs also show the significant weight loss compared to placebo, and that was mostly in fat. So although it is important for us to look at body composition and question that. This was another study that was also like a meta-analysis, and they were looking at various types of medications used for diabetes, and they were looking to see, do these medications decrease muscle mass and performance? So they look for sarcopenia, and their conclusion was that anti-diabetic drug studies should take sarcopenia into consideration. So in addition of looking for how much they decrease blood sugar, they should all, and the cardiometabolic markers, they should also take in consideration how much muscle mass is lost, because muscle mass and function, when we lose muscle mass and function, that exerts a negative impact on glycemic control, forming a vicious cycle with the metabolic disturbance. So I see a vicious cycle. All these nutrients are very important to not develop diabetes. So when there is a deficiency in some of these nutrients or all, we're gonna see a beginning of diabetes and then progression. So when people have diabetes, they get put on medications. These medications will decrease nutrient deficiencies, which then will lead to worsening of the diabetes. So, and kind of the same thing happens with weight management. If we have our patients on Ozempic and Mounjaro, and they will, if they do deplete any of these nutrients, we're gonna see maybe a weight regain in time, like long term, or maybe when the medication was stopped, maybe some of that weight regain would have been prevented if some of these nutrients would have been fully there. So there's no nutrient deficiencies. So potential long-term for nutrient deficiencies. Well, we do know that in biochemistry, we do need a lot of nutrients for the biochemical pathways to happen. And so if we're taking any medication for that matter, but also diabetes medications or medications for weight loss, when we cause these nutrient deficiencies, then we're going to see a cellular energy depletion. And so in our case, that would lead back to more weight regain, potentially just worsening or even adding new disease states. So, and same thing for diabetes. So how to be proactive? As functional medicine providers, we always want to know, well, how do we help? Like, and besides always looking for the root cause, I think it's important to always keep an eye on the micronutrients and making sure that they are not depleted. So my proposal would be for clients that really need to be on these medications for weight loss or for diabetes for that matter, to do a micronutrient testing at baseline and then restore those nutrients, whatever we are starting with, and in the same time start the medication, and then retest periodically, maybe every 3 months to 6 months. And if there are any new micronutrients depleted, those need to be restored. And the SpectraCell testing for micronutrients is really great because it's looking inside the lymphocytes and it's looking for 31 types of vitamins, minerals, and other markers, and including the markers that will discuss the carbohydrates metabolism, immunity, and antioxidant function. There are other tests on the market that do look at micronutrients, but the difference is that they will look in the red blood cell, and the limitation with that type of testing is that the red blood cells do not have any mitochondria. And so any cell that has the mitochondria, as the lymphocytes do, what SpectraCell is using, those cells really need a lot of nutrients to basically make ATP, to make cellular energy. And we do know that when cellular energy is impaired, disease will progress. And these are also some of the other markers that I was just mentioning. And since we're talking about medications that will interact with the blood glucose, this test is looking at glucose insulin interaction, so it will be a good marker for that. And in conclusion, I believe that there is a time and a place for medications, but ignoring the medication-induced nutrient deficiencies only leads to a vicious cycle that leads to more medications and more decline. And as I was preparing for this webinar, because I'm so passionate about drug-induced nutrient deficiencies, I was thinking, how can I help? How can I help more people? And I was thinking that most likely all of you doctors do get one of those clients that you're having them do a protocol that most of the time is very successful, but on occasion, some clients just do not respond to any of those protocols. And my question to you is, if you ever wondered if drug-induced nutrient deficiencies could be the reason. And so I propose to you that if you do have one of those difficult clients and you're just wondering, here's a link to my Calendly. I do have a complimentary assessment session, and I can help you maybe figure out why some of your clients do not respond to your protocols. So I'm going to leave you with that. And if I'm sorry that we had technical difficulties and I cannot get questions, but I hope you'll get benefit just from this recording.
Thank you very much, Dr. Grita. What we can do is just have listeners email us all the questions, and I'll be able to forward them to you. We'll leave the link below on the description here in the YouTube channel and the YouTube description. I want to thank everybody again. Thank you for being patient. This is some great information. I feel like we'll have tons of questions, so feel free to use that link and give us a shout out on any of the questions you have within the webinar. Don't forget, the webinar presentation PowerPoint is down below, so you can download it and keep it for yourself, ask questions, whatever we can do to help you with your patients, we're here for you. Again, thank you very much, Dr. Grita. I know this has been a little bit challenging on the technical side, but we were able to maneuver it. So thank you very much for your time. This is wonderful.
It's been my pleasure.
Thank you. And at this time, I want to wish everyone a good night.
Good night.